Hi, my name's Dr. Allyson Varley, and I am a researcher at the University of Alabama at Birmingham and the Birmingham VA Medical Center. Today, I'm interviewing Dr. Stefan Kertesz and Ann Fuqua about our project. It's called Clinical Context of Suicide Following Opioid Transitions, and for short, we call it CSIOPIOIDS. So, to start out, my first question for Dr. Cortez is tell us a little bit about yourself.
Hello, Anne, and hello, Allison. I am a doctor, as you know. I'm also a physician researcher focused on health services for vulnerable populations. Most of my career has dealt with the types of care we deliver to people who don't have a ton of power or control in our healthcare institutions. That often has meant a focus on homelessness. And in the last several years, I've taken up a real, both a passion and interest in understanding what's happening to people with long-term pain who've been on prescription opioids for that pain.
Great. Thanks, Dr. Cortez. And tell us a little bit about yourself.
My educational background is as a registered nurse. I graduated from UAB in 2000, and I worked until I became disabled due to a neurological condition called dystonia, and then developed arachnitis. And I have been personally impacted by the pain issue.
Great. Well, I'm excited for us to do this interview today and talk about our project. So to start out, why don't y'all tell me what is CSI opioids?
It is inspired by Anne, but I'll go first if she permits me. Is that all right?
Absolutely.
Okay. So over the last 4 to 5 years, and we're having this conversation in 2021, I both observed personally and received countless letters from patients who are in extreme distress as efforts were made to reduce or stop prescription opioids that they had been receiving. And sometimes they wrote me letters or actually saw patients just deteriorate right before my eyes. And the question was, since other people were also having good outcomes from reductions at the very same time, what's going on with these terrible situations where people are being harmed? And I think at an ethical level, I'm just concerned about it. But as an investigator, I also think it's really important for us to understand when things are going very badly in the process of healthcare that we think is supposed to help people. What's that about? We have to figure out, we have to ask about that. And sometimes badly included patients who actually killed themselves or attempted to die by suicide. So CSI opioids is a descriptive study, and what we're discussing today is the phase of trying to show that the people who have lost somebody from suicide might just be willing to speak with a research team like us through a survey, and hopefully in the future through more detailed study where we can just ask basic questions about what happened in that period before the very worst thing possible happened, where the patient wound up dead. And that's what CSI opioids is.
Yeah, so you had mentioned that Anne, had something to say. And so my next question, I think Anne would be a great person to answer. So tell me a little bit about how the idea of studying this group of people came about.
In 2014, I had a really good friend who suffered a myocardial infarction 4 days after being rapidly taken off of his opioid pain medication. And he had been a functional, working full time. He had quadriplegia, but he was a single parent to his daughter. And after watching him pass away, that was, I was so angry, and I kept thinking, like, are other people dying from this? And so, just going online, I was thinking, at first thinking like you're going to, heart attacks and strokes, but I also saw all these patients that had committed suicide that I was learning about. And this was just me sitting on my computer, in the ICU with him. And from there, I just started keeping a list. It started out on my kitchen table. And then from there, now it finally got into a Google Drive and a spreadsheet. And, it was not really anything that would be even thought of being, I would have ever thought of as being something to quote study. I mean, it was just, I wanted to memorialize these deaths, and I wanted to have something to be able to show, the regulators, look, these people they've died. And so I had started collecting, suicides, and then, also heart attacks, strokes, and other things. But the suicides are what we've seen the most of, reported at least.
And so how did you start working with Dr. Cortez on this project?
He found me on Twitter, of all things, my very first tweet back in 2016, which is kind of crazy. But I was really mad that day. And that was the first time I'd gotten on Twitter. And then, a few weeks later, somebody said, no, you need to go back and see, people have replied to your tweets and whatever, And that was how I met Dr. Cortez.
Dr. Cortez, do you want to add anything on about how you and Ann met and how this idea came to be?
So somewhere in the period of 2016 to 2018, I became aware of Ann's list and the fact that she was recording hundreds upon hundreds of deaths. And in my view, when we undertake a change to healthcare with the goal of helping people, if the patient winds up dead by suicide at the end of that, that is not a successful change to their healthcare. The reality was that I felt it would be incumbent on somebody to study these losses. And I even gave a talk where I called on, I think, the Centers for Disease Control and Prevention to study them, because oftentimes doctors would say that changes to care they were making were because of the CDC guideline. And I didn't think necessarily that they would take that up, however. And Ann and I talked a lot more and emailed and texted and eventually met face to face. And I realized that as a researcher, I didn't think our institutional review board would let us just sort of take data that Ann had collected privately, where we don't know if those families that are reporting their losses had consented to the use of that information. And I didn't want to chance it. So what we decided to do was to try to set up a recruitment where people could interact with us voluntarily if they were the survivors. And Anne certainly could reach out to families that she knows, but we wouldn't assume that we have consent just because they reported a loss on Facebook or something like that.
And I think that's like the only fair way to do this, because people post on Facebook and they may think something is not public. They don't think about things being publicly accessible or not when they're grieving. And it could be a relative, but then that could not be the person with legal, power to consent for the patient that posted.
Great. So you've said that you've got this study that you've started based on this collaboration you've been building for years and looking and building on this list that you've built. So what's the goal of this study?
Well, it's worth thinking of it as being in two phases. Essentially, we're in phase one. We have what's called a pilot study. And the step is to see if we put ourselves out there and show that we're concerned, how many families and survivors will willingly agree to engage with us. Because if you look in the long term, the only way to really figure out what's happened with these terrible losses is by very, very detailed study, by looking at medical records and detailed interviews, which will require resources. But the step one is no one will be able to ever study these deaths unless the survivors agree that this is worth their time and that they're willing to trust somebody who's affiliated with a research entity like a university. So we're in phase one. We're putting ourselves out there. We're saying we're here. We're governed by an ethics board. We have a survey. That's it. And we're trying to find out a little bit of information about the loss you believe you suffered and to learn whether you're willing to be engaged with researchers. There are 1,000 reasons for the families that have suffered these losses, 1,000 reasons for them to not want to talk to people from medical professions of all people. And we essentially have to say, we know that, but will you make an exception for people who are really, really concerned about these losses and who have, the credentials to do research? So for now, CSI Opioids is a survey to get people who are willing to talk to us. And if we can get enough people who are willing to talk to us, we believe that a larger project can follow where a true multidisciplinary team of suicide experts can try to understand what happened during these terrible losses.
Okay, so you have this survey. What's on the survey? What does the survey look like?
Yeah, so if a person wants to do our survey, they can either telephone in to the research team, and there's live human beings who can do the survey by phone, or they can participate online at our website. And there's about 40 questions. And the first few questions are just trying to figure out if we are allowed to ask you the other questions. A person will be shown information about the study that we're required to show as an ethical requirement, that you know that we're not paying you if you want to be in the survey, for example. And then it asks, do you think that you have someone close to you who died by suicide after a change in pain medication? If you don't believe that at all, then you would kind of exit the survey there. You also have to be an adult, and you have to be in the United States. And the person who died has to have been in the United States. And those are all kind of regulatory steps. And then there's about 36 more questions about, well, what do you know about this death? Because people don't necessarily know everything. They know a little bit. Do you think that they had pain medications ongoing? Do you think those medications were increased or decreased or something else? What do you know about how the person died? And the questions are usually just multiple choice with some space to write in extra information. It probably doesn't take more than 10 to 15 minutes to do. There's not a payment for doing this, and the information is stored securely and confidentially according to the rules of the University of Alabama at Birmingham's Institutional Review Board. It's not shared out there, and it isn't distributed.
Okay, so are you trying to prove that taking people off of opioids causes people to die by suicide?
This kind of study isn't really set up to study a simple cause and effect relationship like that. What we're saying is it's obvious that there's people who are dying by suicide. There's enough observational data published to show that some number are, even if other people go off of opioids, and it's a great thing for them. But what we're asking is, when the bad thing happens, how and why does it happen? The kinds of things that we could ask and learn are, when these terrible outcomes happen, when there is a death, how many of those folks were willingly going off of their prescription opioids? How many of those folks had good family relationships supporting them at the time that that happened? How many of those people had other serious, maybe mental health diagnoses at the same time? Ultimately, when you study a selected set of cases where something terrible has happened, the kind of insight you get is descriptive and qualitative. It tells us about how and why bad things happen, which is a little bit like the kind of study we do after airplanes crash. When an airplane goes down, it's the ultimate disaster. A team is dispatched to look at what happened that seemed to go wrong, that this ultimate tragedy happened. No one comes out of that saying there's a simple single cause and effect. If only one thing was different, these planes don't go down. There's no randomized controlled trial to assess whether airplanes go down or not based on a single circumstance. Rather, you develop a holistic picture of, why did this terrible thing happen, and how can we prevent it from happening in the future? And that is the scientific extent that we can go to. And that's also a moral commitment for us.
Okay, so you just said that with this study, you'll find out the why and the how these things are happening. And what happens after that? You said that this was in preparation for something larger. So what happens when you find out this information?
Maybe to be very clear, the initial survey shows how many people are willing to talk to us, and it shows us some initial information. And that's what we're doing now. With that initial information, we would seek support from a large agency of some kind to develop the sort of study where you actually do very in-depth interviews with the survivors. That's called psychological autopsy. We actually have nationally renowned suicide experts who have joined onto our study team who are willing to help us with that. And we also can review and collect medical records to try to make sense. The story that emerges from studying 100 or 200 such terrible deaths is a collection of insights about what seems to be the problem when we are losing patients in healthcare. And we would try to assemble those ideas and share them with stakeholders, including the families who are still surviving, and including health care providers, healthcare regulators, and potentially even the people who are setting the rules for how we prescribe opioids and how we deliver pain care in this country, and say, None of you should want this outcome. Here are how some of the bad things are happening. Let's ask ourselves, are there ways to alter care or programs we can develop to prevent these things from happening? And then we can test those programs.
Great. So you mentioned that you've got some suicidologists helping, but tell us a little bit about the team that's working with you on this project.
Okay, well, first of all, we have Ms. Fuqua, who's at the bottom part of the screen, the way I'm looking at it, at least. We have a health systems implementation scholar in the form of yourself, Allyson Varley. We have 3 experts in suicide, 2 from the University of Alabama at Birmingham, Caitlin Clevencher and Yogesh Dwivedi. We also have the support of Tom Joyner, who's one of the most prominent suicide researchers in the country, maybe in the world, from Florida State University. We have advice and insight from people who are experts in opioid and pain care at the front lines, people like Beth Darnell from Stanford University, Adam Gordon from University of Utah, Salt Lake City, and a number of people who is interested in health systems implementation, how you change healthcare in this realm. The other thing to note is if we get to the point where we can collect medical records and carry out that kind of interview-based work, we'll be working in concert with the University of Alabama, Birmingham School of Public Health, and I would hope the Birmingham Veterans Affairs Medical Center. We're waiting to see which funding agency, if any, will support that work.
Okay, so I guess circling back to the survey, so say I think that I want to be a part of your study. Who can be a part of the study? Who can fill out the survey, and where do you go?
People who want to participate need to be adults, and because we're in Alabama, they have to be 19 years of age or older. They have to believe that they have lost somebody due to a change in prescription pain medication. It actually could be starting it, stopping it, increasing it, decreasing it. Any of those would apply. The person who they lost would have to be someone who died in the United States rather than another country. That's just because of the regulations around our research. And if they want to participate, they can go to our website, or they can telephone the study team, and there's paid staff who are able to administer the survey. And then they go through a set of initial qualifying questions, which is about 4 questions, each of which is yes, no, and then about 36 more questions.
Okay, and you said that you're in Alabama, so you have to be over 19, but anybody from any state in the United States can participate in the study, right?
Absolutely, and the territories as well.
Great. So you've been working on the study for quite some time. How long has the survey been out?
Yeah, we started on November 2nd. I think it was the day before the election. So at the day that we're speaking now, it's been about 2 months, and we have hundreds of people who've come to the website and several dozen who have completed at least some of the questions and appear like they might qualify, and 27 people who have completed it in full, which is a really great start.
And Anne, you are our recruitment coordinator. How are things going on your end as far as recruitment goes? Are you getting any specific questions you think we should address here?
I've gotten a lot of questions from people that have repeated over and over again. And many of them have been about things like, well, what if I'm not sure that person committed suicide? What if the medical examiner, says it's accidental, but we think it's a suicide and I've got a reason that I think it's a suicide? Or what if I have a suicide note from my relative, but the medical examiner ruled it accidental, which is probably the most frequent. And then beyond that, I think one that's really important to address is, well, why aren't you studying people that are thinking about committing suicide? Why aren't you studying people that have welfare checks from the police? Why aren't you studying people that have or talking to doctors who have gotten documentation and patients paperwork that they fill out saying that they feel suicidal? And I think that's something that's really important that we need to address. Both of those.
Those are both really great questions. So first, Dr. Cortez, can you address the first question that Anne brought up? And that was,
It has to do with the fact that there can be uncertainty, or maybe that the medical examiner does not endorse. The reality is, the way the study is set up is, if the respondent to the survey thinks that probably there was a suicidal aspect to it, they should go on into the survey. There is room in the survey to explain what you think happened and your level of confidence as to whether this death happened as an intentional act or not. And the people who are carrying out the study, including our 3 renowned suicide experts, are very, very familiar with the fact that sometimes the story that the medical examiner lands on is different from what the information might suggest and what the family has observed. So we're very, very receptive to any kind of story where the gestalt, the basic thought is, I think this person might have died by suicide. I'm not sure. We can work with that. There's this other question, though, which is that for every person who has died by suicide, there are hundreds or perhaps thousands of Americans who are in the process of having their care changed, who are experiencing profound distress because they do not have control over this change that is happening, and whose fate has been, in my view, fully discounted by our healthcare system and not taken seriously. And the question they ask is completely obvious, is why aren't you studying the fate of people who are everything from feeling terrible to being about to kill themselves? That group needs an immense amount of attention, in my view. Our challenge at this very moment is we have not sorted out the ethical approach to trying to carry out research with people who are on the edge of dying by suicide. That is in part because as soon as you propose a study where you're going to work with people who are about to die potentially by their own hand, the people who regulate us ask, okay, so how are you going to protect them? And if you think about the conundrum that is opioid prescribing and abandonment in this country at this time, we as investigators sitting in Alabama or California or Florida do not know how to protect these people, which is of course what is maddening about all of this. And that's why we're doing this research. So essentially, at the first pass, what we suggest for people who are in this extraordinary situation of distress is to go ahead and use our study email address to at least let us know that this is something that matters to you, and even a paragraph about what's going on. That does not mean we can intervene or that we can formally use it as research data. We won't. But it may mean that in the future, if we can build up a team with resources, we can begin to offer some kind of study that would address these very dire situations. I have letters and letters and letters of people who are in these desperate straits. And we do ultimately want to get to that. We haven't figured out the path to do it ethically.
okay. So I guess my last question is for you, Anne. Do you have anything else that you want to add about how the process is going and, how the study's going so far?
I think the response so far is actually it's been very positive. There's been lots of interest. And I think that for families that are grieving a loss, it's tragic and it's horrible. There's nothing that can be done to bring back their loved one. But I think that participating in this study is one of the most important things that they can do to help ensure that no one else down the line has to suffer as they have, and that we can stop these needless tragic deaths.
Okay. And if someone wants to contact you and reach out to you to find out about the study, how can they do that?
They can contact me by email or Twitter or Facebook, and we've got those links on the screen.
Okay, great. Well, I think that is all the questions I have for us today. Thank you guys so much for your time. If anybody has questions about the study, I'm posting the information right here. We have our contact information and then information about accessing the study. Thank you so much.
Thanks.